All right, I was trying to find videos. I'll find a video with adenomyosis. That was what I was trying to show. Let's see. All right. I'll turn my audio off until, oh, sorry.
Good evening, Endo Summit Live, and welcome to Adenomyosis Night. It is usually a much anticipated evening, which in some ways makes me sad that so many people need to tune in to hear about adenomyosis. We are joined this evening by Texas by from Dallas, Texas, Dr. Rachel Haberlin. Dr. Rachel is in a new practice. Can you introduce yourself a little bit?
Thank you, Sally, and thank you for having me to the Endometriosis Summit. I'm really looking forward to seeing you in person in March. So my name is Dr. Rachel Haverland. I am in Texas. I'm Texas's endosurgeon. So I started my own group, Endometriosis Center of Excellence, as of November. So we're a few months in, and it's really exciting. Women deserve these high quality, evidence-based cares, and it's really just a place for just endometriosis, just focusing in. We'll touch on adenomyosis today because a lot of the times it comes hand in hand, unfortunately. But I'm really excited about it. It's going really well.
I believe when we set up this webinar, there was some discussion about talking a little bit about teen adenomyosis. And I think there's too much silence about teen adenomyosis. What do you think?
I agree with you completely. And I think, in my mind, I'm a little bit biased because all I see in my office is endometriosis, women with endometriosis symptoms. But I think it is really important to keep that in the back of your mind because we see it all the time, 16, 15-year-olds, and it's pretty obvious. And if we can catch it early, at least they can get some answers and maybe some, more treatment options. But it is, I don't know if it's becoming more common or just we're starting to talk about it more, or I'm starting to see women that are just advocating for themselves at a younger age, so they haven't had to suffer for as long.
I think that one of the things that advocating for a correct definition in endometriosis has brought awareness to adenomyosis because, of course, endometriosis is not a uterine disease, but adenomyosis is a uterine disease.
Yeah, very much so. And it sometimes is confusing for patients and even other doctors that don't really understand endometriosis because the definition of endometriosis is these cells are outside of the uterus. They're ectopic. They are not implanted in the uterus. And then when I start talking about the uterus causing pain and inflammation, that's actually a very separate disease. Yes, they can be similar, in how they present and some of the symptoms, but very different diseases in general. And adenomyosis, one thing that's kind of nice is we are getting a little bit better about being able to identify it on imaging, whereas early stage endometriosis is still really difficult to identify on imaging, at least.
Yeah, so do you want to share what you used as a definition for adenomyosis? Or are you going to make me look it up?
I can do it. So, adenomyosis, just as kind of like a basics, is where the lining of the uterus kind of grows into the muscle wall. So, the uterus in general should be hard like the back of your hand, like a hard muscle. But with adenomyosis or adenomyosis, depending on where you are in the country, you can say it both ways. The uterus is boggy. It's kind of heavy, like a sponge. So it's soft. But essentially, the lining of the uterus kind of grows into the muscle wall, and these cells sort of secrete fluid, and so it becomes edematous, almost like if you've been on an 8-hour plane flight, just like your ankle would be edematous, same thing in the uterus. And when it does so, it just causes inflammation, and so the uterus itself is inflamed. You can identify this on imaging to some degree. Sometimes with early adenomyosis, you don't see it as well, but truly it's a measurement of the uterus itself. And usually there's conflicting data, but usually it's 8 millimeters or more is definite is the definition of adenomyosis. But they also look at the heterogeneity of the muscle. So the muscle of the uterus should be very homogeneous, meaning that it looks the same throughout. Heterogeneity is where there's little lakes of fluid, so there's little pockets of darker appearing tissue, and that's when they call it heterogeneous, or they're measuring it, and that pocket of fluid kind of makes it thicker as well. So I use 8 millimeters or more, but if it's between 6 and 8 and they have strong symptoms, then I still consider that in my differential.
Now, when you talk about millimeters, you're measuring, again, can you just clarify where you're measuring?
Yeah, so we're measuring on the uterine wall. So sometimes you'll get a measurement where they're measuring the endometrial lining. That is not what we're measuring. The endometrial lining is completely different. That grows and sheds with your period. So depending on where you're on your cycle, that lining can be different. And so this is not the endometrial lining. This is actually the muscle wall and the thickness of the wall of the uterus.
So what is, lots of patients ask me about the junctional zone, which the junctional zone will get into a little bit of controversy with that and adenomyosis.
Yes. Yeah. So you use the correct terminology. I'm sorry I didn't do that before, but yes, it's measuring this junctional zone, and it depends on, you and I both know it all depends on how good the ultrasonographer is, their angles, exactly how they're measuring, if they're over calculating or under calculating. I think the best way to look at this is personally MRI, because it's a little bit more straightforward, but ultrasound is also a lot more accessible to most of our patients. And so I always hate to leave barriers to my patients for additional treatment and, diagnosis. So if we can try to get it with an ultrasound, we certainly do. But it depends on which papers you're looking at. Between 6 millimeters and 8 millimeters, some people say that may be definitive. Most papers recognize that 8 millimeters or over. There's a few papers that want it to be 10 or over, but even though adenomyosis technically doesn't have stages, when it's getting that thick, it's really quite obvious when you're looking at it on imaging.
Yeah, it's interesting. Our good friend Antonio Gargiulo, who at one time was really head of uterine transplant, I believe, at Brigham and Women before COVID, and then COVID like kind of ruined all that. But he talks about how lots of patients, especially fertility patients, will go and maybe they'll have eventually an MRI, and it'll come back and they'll say, well, your junctional zone said blah, blah, whatever it is, that's it, we do a hysterectomy. And he really talks about making people make decisions based on symptoms and not on what you see on the imaging. Do you find that?
100%. And that's literally the world that I live in. I mean, because I talk to women with endometriosis all the time who've had quote normal imaging or adenomyosis symptoms that still have, normal imaging, and everything is based on symptoms. I mean, my job is actually so easy. I just believe women when they come into my office and they tell me their symptoms. I try to listen and understand, but I just believe them when they're telling me that their pain is debilitating during their cycle, that they're hemorrhaging, soaking pads, you know, you know, copious bleeding during their cycle. That is indicative of adenomyosis. I don't care what their imaging says. Yes, we look for other etiologies of the bleeding like polyps or fibroids, but in absence of those, it's adenomyosis really till proven otherwise. And most of my patients come to me with the goal of fertility sparing treatment. Most of my women are young women, or they just don't want a hysterectomy, and that's also okay. This is your body. You get to make decisions for your body. And so trying to give different options, it kind of depends on what their goals are and when their goals are fertility are. Like, are they actively trying for fertility? Like, are they seeing a fertility doctor? Or are they working actively on fertility? Or are they 20 and maybe they don't want to plan for this for another 5 or 7 years, but it's in the back of their mind. It's certainly something they've always wanted. Or maybe I have a slightly different, discussion with somebody that's 47 and has completed their family, or they never wanted children, which is also completely fine. Not all women are made to be baby makers. But it kind of depends on where they are. But my job is to make sure that my patients know all of their options. And then we get to make decisions together, because they know their body better than I do. They've been dealing with these symptoms for years. And so, I want to give them the evidence. I want to give them the treatment options, but I certainly want them to feel like they're getting to make these decisions for their body. Rather, it is a hysterectomy, which is technically the gold standard because you're taking away, but there's still other options there. And so it doesn't mean that this has to be your, definitive answer, because a lot of women get some benefit other ways.
Yeah, so we had a different Rachel on, Rachel Rubin, who
Uh-huh.
one day I'm gonna like beg to have her at the Endometriosis Summit, but of course she is probably one of the nation's preeminent hormone specialists.
Right. Yes.
And of course I'm a Sorel, so that goes into my background of hormones as well. And I think one thing that we have to add into the conversation about adenomyosis is if we take your uterus, even leaving your ovaries, you're still going to go into menopause sooner. And to me, the health risks of menopause, heart disease, stroke, Alzheimer's, weight
Yep.
gain, thyroid issues, neurodegenerative diseases,
Yep.
I think this is the frontier that needs to be added into the informed consent when we talk about hysterectomy.
I agree with you 100%. And I talk to my patients about this. So many people have been counseled, and this, you see patients, they've seen other doctors that maybe don't understand, or maybe they're very old school. They're like, just take it all out, honey. You'll feel better. We take the ovaries, we take the uterus, we take the cervix. Then we'll just put you on HRT and it'll be fine. That is quite, when you're not the one going into surgical menopause, it's easy to say that. And it is very important to talk about these. I mean, we talk about the risk stratifications, right? Thin white woman comes into my office. She's the highest risk of osteoporosis. What are you going to do for your bones? So many of my patients have tried hormone replacement in the past and they don't do well on it. Rather, they haven't done well on birth control pills or they haven't done well on other things. And so if I take your ovaries out, what are you going to do? Because that's your option, and you should be on some sort of HRT until the average age of menopause, which is 52, and you haven't tolerated it in the past. So it just, it's a really important discussion to have, because many women don't get that discussion until afterwards, and then they're kind of cut.
We're going to do a deep dive at the Endometriosis Summit, but I also would say people aren't tolerating the pill or hormones because they haven't had their endometriosis completely excised. And once you've had the endometriosis completely excised, then life is a different story. But let's go back.
I agree with you.
Yeah, let's go back to the topic.
Okay.
The first is what do you see as symptoms of adenomyosis?
Yeah, and so adenomyosis is sometimes a little bit sneaky because the symptoms can overlap with endometriosis. So when I talk to women about adenomyosis, it's typically, now not everybody, everyone has slightly different symptoms, but classically it is pain during your cycle. They cause this heavy inflammatory response during your cycle. You can have heavy bleeding, prolonged bleeding, which is more than like 6 days, and heavy bleeding, prolonged bleeding, and then pain with your cycle is usually what I'm looking for to kind of differentiate. Now, endometriosis absolutely can cause you pain during your cycle, but it doesn't necessarily affect the amount of bleeding that you're having. So yes, endometriosis is affected by hormones, but usually if you're having really heavy bleeding, casting clots, soaking a pad an hour, ruining your clothes, there's usually something additional to the endometriosis that's going on. And if a patient comes in and we know they have endometriosis, that also heightens my suspicion because so many times they go hand in hand.
Right. So I also would add a bowling ball like sensation in the
Yes.
pelvis. If
Heavy.
they all say that. And another one I would add is people call it a hot poker like feeling inside. That's a big one. And the bloating is an abdominal distension in the front. It's not just
Yeah.
like I'm bloated, which is sort of like everywhere. It's
Yeah.
this all of a sudden I look completely pregnant.
Pregnant. Yeah.
Yeah.
And I have patients showing me this and they're like, look at me in the morning and look at me in the afternoon. I mean, or look at me a week in between. And they see that bloated, but you're right, that heavy, that, I was mentioning earlier, the boggy kind of fluid filled swelling. That's exactly what's happening. And that's exactly what they're feeling. So I agree with you. Those are all good ways to explain it as well.
So this Endo Summit, we're going to talk a lot about the hypogastric plexus. We, of course, have the cadaveric dissection in the cases. What's your take on why adenomyosis contributes so much to bloating? They're
I
hard
think it's
questions this year, right?
I
You're
know,
like,
but I
last year I
like
had
it. I
somebody
like
with
them
me.
though.
Yeah,
I like it. We're getting
yeah,
to the root.
yeah.
I think it's because of this just huge inflammatory response. And it's kind of filling the whole pelvis and your organ systems are right there. So, when we see pictures, the bladder is up here, the uterus is here, the rectum is here, the vagina is here. That's actually not how it is. In surgery, we separate everything and blow it up, but they all live in a little spot, right here together. And so inflammation in one area certainly affects the other. And so inflammation, all the tissues are kind of get swollen, but it also affects the bowels, and the bowels kind of bloat too. So it's multifactorial in my opinion. But I think the root cause is coming from that uterus and just this huge inflammatory response. And I talk to patients too, especially ones that are desiring fertility after endometriosis excision surgery. Even if we know you have adenomyosis, sometimes once the endometriosis is gone, the symptoms during your period aren't quite as severe, even though that we know you likely have adenomyosis, just because of some of that additional inflammatory response has been removed and cleaned up. But yeah, that big, heavy, just swollen, inflammatory area, and then the bleeding. Now we know that endometriosis does not spread by retrograde menstruation. That's been proven, and we discuss that a lot. But you do get blood in your pelvis during your cycle. It does come back through, and even though that's not how endometriosis spreads, it's very caustic. A lot of women have, a change from chronic constipation to diarrhea during their cycle, and some of that's because their bowels are being bathed with blood, and that's certainly irritating and can kind of make the bowels move more quickly. But it's just this whole inflammation.
Now, another symptom we didn't touch on yet is leg pain. Leg pain, very, very common in the adenomyosis patient. Why do you think that is?
Well, when this uterus is heavy, I mean, I have a lot of patients ask me, do I have endometriosis on my sciatic nerve? And sometimes they do, but a lot of times it's this big, heavy uterus laying there on the sacrum. And those nerves are running right underneath the sacrum. And they're also inflamed because, like I mentioned before, everything is in very close proximity. And so these nerves that are radiating down the back of your leg or even radiating to kind of to the groin area, it's because of this inflammation, and it just kind of is sitting there because it's heavy, and so it's a little bit more irritating, and it certainly can be related to endometriosis or truly endo on your sciatic nerve, but a lot of times it's just the uterus or endometriosis kind of radiating down there.
Right, that's our friend Abhishek Mangishkar. He loves to
Yes.
talk about posterior, he's also a neuropelviologist. He loves to talk about posterior adenomyosis compressing the sacral plexus and the sacral nerve chain and really causing a lot of leg pain. And my experience as a PT is that the leg pain from adenomyosis is sort of like all over leg pain. You can't sit there
Mhm.
and point out one nerve.
Mhm.
So it's multiple nerves in the back of the leg,
Yep.
in the front of the leg, in the groin. Whereas when it's sciatic or it's a hernia
Mhm.
or you can point out that one
Yep.
nerve. Yeah.
Yeah, I think you're right. And it's usually bilateral, not always, but sometimes I notice that it's more bilateral that way too. Um, Sometimes I feel like it's a little bit clouded with pelvic congestion syndrome because of that leg pain.
My
Um,
next question.
wow, just leading you into
I
it.
know. Yeah. So it's interesting because this year we have a full hour. They stopped calling it pelvic congestion and now it's pelvic venous disorder,
Okay,
right?
yes, yes.
And so what is the relationship between the pelvic veins and adenomyosis? Because I don't know if it's just the size of the uterus or what goes on, but I think that pelvic vein issue is huge.
Very obvious. When you get in there for surgery, you see these veins and they are big. And I think it's multifactorial, but when your uterus, usually women with adenomyosis, their uterus is enlarged and the tissues we talked about are thicker and there's just more cells to feed. And so the blood supply becomes more robust. This happens with fibroids also, but I noticed with adenomyosis, the blood supply is when you visualize it, it's quite impressive, almost like varicosities in the pelvis. And when you see them, they're dilated, sometimes more than, a centimeter and a half, even 2 centimeters, quite substantial. And anything, the uterus is not made to have blood supply like that unless you're pregnant, because there's nowhere for it to go. It doesn't rotate out the way that it should. The arteries bring in the blood, the veins are supposed to take it out. But when you have kind of too much coming in, it's also sort of feeding this adenomyosis, and there's nowhere for the veins and lymphatic systems to really drain very well. So I think that also contributes to some of the pain in the legs. Some women feel pain with sitting for longer periods of time, feel better when they're standing. I think just because things are able to move better.
Yeah, it'll be interesting. We have Brooke Spencer coming.
Yeah, I'm looking forward to that. I saw that actually on the itinerary.
And then we have you who can talk one language, and then Anna Sierra, who's really into the way the veins interact with the nerves. I should have made a whole panel but
I know. Well, I'm looking forward to that. I think that'll be great.
You needed the basis, I feel, of she had to start with like what it is before. Yeah. I'm trying to talk her into that we all have to cover our veins with blue stickers and our arteries with red ones, but she doesn't get the Sally yet. She doesn't get that. I would send that message to you and you'd be like, okay, great. But she doesn't know me, so she doesn't really know I'm serious.
Yeah. I mean, what's cool about Endometriosis Summit is there's providers there's patients there's so many different levels of knowledge based on what we're talking about, but everybody is very well educated just in their own little niche. Rather, to patients, like, they're well educated on how to advocate for themselves at this point, coming in to learn more about that, learning about treatment options, but also they just know their body and they know their symptoms. And then different providers are able to give a little bit more information. And last year I remember learning quite a bit. And even though this is what I do every day.
The other Rachel, because now I'm throwing it out into the universe because we're going to try to make it work. Okay. Rachel Rubin had this idea that we should almost form a brain trust the day before the summit or like the day after the summit, and pretty much lock all these providers that attack the problem from a different aspect in one room and not let them out until we come out with a consensus.
Yeah, I love it.
And
I mean, what happens when we all get together? We go a little stir crazy, but I think it'd be really fun. You might have to be there to keep us in line, though, Sally.
You just have to lock out most of the male providers. Not all of them, but just most of them.
You said it, not me.
Yeah, I'm allowed to say it because you are the founder of what's our all female surgery panel. You and Megan Wasson decided that was going to be what we were going to. You told me that last year. We're doing it this year, but
Megan was my mentor in fellowship.
I know, so and all of you gather.
Yeah, she's leading the way.
Yeah. So I have some questions. What is an adenomyoma? And how do we tell the difference between adenomyoma and fibroid?
This is a great question. So sometimes we can see a conglomeration of a smaller, more spherical area of adenomyosis. And technically we call this an adenoma instead of a fibroma or a myoma, which is more consistent with a fibroid. Adenomyomas, or a myoma of adenomyosis, it tends to be really soft. So a lot of times we're going into, if we see one on imaging and we're going in to try to remove it, the planes usually aren't as clear as compared to removing a fibroid, because a fibroid is more, like I talked about, like hard muscle mass, whereas adenoma is spongy and it's soft. So sometimes the planes aren't nearly as clear. Removing an adenoma is not as satisfying as removing a fibroid, because usually when you remove an adenoma, I know, well, it can be, but so many times when I remove the adenoma, there's still adenomyosis in other aspects of the uterus. So this may help, improve some of their symptoms, but the likelihood is that there's still some adenomyosis in the other portions of the muscle. Rather, even if this is the portion we can mostly see, there's just a likelihood that it's still in other places as well.
Right. So I'm going to, first of all, this conversation, adenomyoma versus fibroid, is the very first online conversation I had with Dr. Redwine. So it always makes me a little sad to talk about it
Yeah.
again.
He was such a special man, such a pioneer for endometriosis. Last year, it was really neat that we gave, that we were able to talk about him a little bit.
We miss him a lot every day.
Yeah.
Even when I wear shirts, we miss him. But
Yeah.
so one thing that I will say is somebody who pursued, and at the end I'll explain why I pursued this.
Sure.
So with the adenomyoma, um, for that person that isn't ready for the hysterectomy,
Sure.
they perhaps have a connective tissue disorder. They don't want to get
Mhm.
involved with sewing a
Mhm.
cuff. They're seeking fertility. There are many that try to take that adenomyoma out, but they accept that there's adenomyosis, which is diffuse in the muscle wall that
Yep.
cannot be removed. And I see more and more discussions on that rather than just saying like, hey lady, you have adenomyosis, you can't remove it, you have to
Yeah.
do a whole hysterectomy. I think the
Yeah.
informed consent really needs to include it's an
Yes.
option. Yeah.
I agree with you 100%.
And the
And
patient
and
takes the risk that they'll have to go.
exactly. And exactly. And if they even get a small amount of benefit, then it's worth it. But also maybe that is like poking right in the back. Maybe it's giving them more pressure on that, sacral nerve plexus. Maybe it's pushing on their bladder. Maybe it's like more, more on one side than the other. There's many reasons to go do it, to remove that area, understanding that the adenomyosis is still there, but it's certainly reasonable. And that's why it's so important for patients to be given every option.
Yeah.
Not to come in and be like, "Oh, honey, you should just take it all out." Well, that's doesn't fit for every person. And
Wow.
I don't recommend that for hardly anyone.
No,
Um,
this is another one we could lock everybody in a room about until we came to a consensus. I found it interesting also because Dr. Gargiulo at one time worked at the Brigham. There is a time limit on the age of someone, you can go removing the adenomyoma as well as the fibroid because of guidelines that were established, I want to say about 10 years ago. Can you imagine we're 10 years past morcellation? Yeah. So
that kind of is crazy to think about.
right. He starts to he's it's up on our YouTube, but really about age 43, 44, you don't want to be poking the uterus anymore and you start to have to think about taking the whole thing. That's the guideline. Do you follow those guidelines? I mean, they're not hard and fast rules.
Yeah. So I'm not a rule follower. I actually in real life I am a rule follower. In real life I follow all the rules. But when it comes to this, it is not a one size fits all. And every
Right.
patient has different symptoms. Every patient has different goals in life. And it, we talk a lot about fertility here. Most of my patients come to me with that goal in mind. I also have many women who have never wanted children, no children by choice, and they still don't want a hysterectomy. That's still not a good reason for a hysterectomy. There's a lot of discussion that should go into these recommendations. And age has something to do with it, but it's all a personal decision. So no, I do not. I don't follow those guidelines. I give recommendations based on symptoms, based on quality of life, and what their goals are. But just because I give a recommendation also doesn't mean that's what they have to choose. We kind of go through everything, and patients choose. I feel very strongly in autonomy for my patients, them getting to make their decisions for their body. And a lot of times when there's this discussion and they hear me understanding them, their goals are my goals. So usually it's pretty easy.
Yeah, I think that concept of just because you recommended it doesn't mean that has to be what the patient chooses,
Yep.
can be important. I think we're going to expand in the future on how connective tissue affects the person with pelvic pain and endometriosis. And I see more and more in my practice that those with that wonky connective tissue, maybe they have a little POTS, maybe they're in the
Mhm.
pelvic congestion family, maybe
Yeah.
they're hypermobile, not necessarily EDS, but they're hypermobile. They don't want the hysterectomy. They
Right.
don't want to,
Right.
you know,
Risk of prolapse and bladder symptoms. Yeah, I get it. And you know, we could have a whole nother discussion about endometriosis and EDS because I have
Yeah.
seen such an increase in my population, usually the hypermobile type. Some of them have the vascular type, but it's also something important to talk about. And people that don't do endometriosis all the time or aren't familiar with these other like POTS, EDS, these other comorbidities that are frequently seen with endometriosis, they may be giving bad information or not, at least not consenting them correctly on all of the risks that they may have, and especially ones that they may be a little bit higher risk for because of their connective tissue.
Yeah, I think the newest guidelines for that is that it's no longer you could have POTS or you could have mast cell or you could have hypermobility, that it's actually a spectrum. So if you have a piece of one, you usually have a piece of all of them. I mean, that's not
Yeah,
all our patients, but
a
I
lot of them.
see
Yeah.
that I would say I see 50% of our patients have some component of that.
Oh yeah. Yeah.
Yeah, of
I think you're
mine, I
absolutely
see
right.
very complex. I don't see, like you, we don't
Yep.
typically see the patient off the street, you
Right.
know.
No, most of the patients have seen, what is it, 7 to 10 providers, taken 7 to 10 years to finally get into just the networking so they can get appropriate treatment. It takes that long just to get plugged in. But yeah, I agree with you. Almost everyone has specialists, and it's also very good, to have these specialists. But unfortunately, a lot of it's still related to their just chronic inflammation.
Yeah, so let's talk more about adenomyosis.
Yep.
Somebody comes to your office. What are the options with adenomyosis? Because we may not choose suppression, but there are some options before hysterectomy, right?
Absolutely. So the first thing I talk to them about, where are their symptoms? Because if you have adenomyosis, your risk of having endometriosis is incredibly high. So most of the time, this also is a discussion of endometriosis excision surgery and thorough excision. So, and I know that's not what we're talking about today, but usually it goes hand in hand with that, making sure that the endometriosis is out. So we're just focusing there on the adenomyosis. And adenomyosis, unlike endometriosis, does respond well to progesterones. It does. And so we talk about the different options. So you can do traditional estrogen and progesterone birth control pills. I call them the combined, birth control pills, and there's hundreds. Progesterone only pills. Sometimes I use both Slind, which is a relatively new, that drospirenone technically is a contraceptive, but we're not using it as a contraceptive. We're using it for the adenomyosis. Agestin, I'm so old school. I like the Agestin, but progesterone only options. And then I do offer IUDs. I only place IUDs at the time of surgery. I don't have the tools. I don't have the pain medicine. The women deserve to have treatment with good medical care, but also with pain control. And I don't have that in my office. I
Now,
really don't. And so if I
now we
place it at time of
beg.
surgery, do what?
By the way, we begged this company that I had met, and they do in-office nitrous oxide for
Yes. Mhm.
placement of IUD, and they're based in Orlando. I begged them to come to this.
Ah, that would have been awesome. I actually have nitrous in my office, believe it
Yeah.
or not. But usually I'm using those for like the receptivas, people, and there's a kind of a fertility component over there. But even with nitrous, sometimes it's not enough. I mean,
No.
it's like when you're getting your cavity filled and they give you a little nitrous, you still feel a little bit. And so I only place IUDs at the time of surgery. It's just my preference, but also I know that it's placed correctly. I can see it go in. It's not going to, go to your liver. And again, it's a personal decision. I have so many patients that are like, I don't want something foreign on my body, and that is completely fine. Or I've tried birth control pills that really affect my mood. Or, there's a lot of different reasons to try different medications. I do think there's some component of, strict diet changes that may get you some benefit there too. Just helping with decreasing inflammation, not making the adenomyosis go away, but helping with some of those the symptomatology.
Now, with the IUD that contains progesterone, Dr. Vidali likes to say, like, even though recommendations say is for 5 years, for the adenomyosis dose, which by the way is off label, you need it replaced much earlier. Is this something you talk
Yeah.
to about patients?
Yeah. So Mirena, the one that's kind of the one that's most common, is it keeps having its life extended, but that's really for pregnancy prevention and contraceptives, not for treating, adenomyosis. And so usually I say about four-ish years for the Mirena, but also if you're at 4 years and you're doing pretty well, like you could try to space it out because everybody's a little bit different. But usually you will need more frequent than that, than the stated time for the IUD intervals.
Yes, I didn't. We have
Yeah.
so many questions. We're going to have to do much more. April is Adenomyosis Awareness Month. Are you going to come back for that? Yeah, we're going to have you back for that. So we have a
I would love
question
to.
from Facebook.
Okay.
And the question is, does adenomyosis cause infertility and how?
So
And
that is
how? No.
yeah, and how
Yeah.
it's tough. Adenomyosis can affect fertility. With that being said, I have women with adenomyosis that get pregnant all the time. Same thing with endometriosis. It doesn't always follow the rules, but it can make it harder for implantation. And that's where it really affects fertility. The uterus is just a little bit inflamed, so it's not as much of a happy vessel to harbor this embryo. But again, I try to tell my patients, do not lose hope, because there are women that get pregnant with adenomyosis all the time. That's much more extreme, than what you're, expecting. But at that point, if we know you have adenomyosis, I'm like, just optimize everything else. Really work on clean eating, take care of your body. Which is easier said than done. I'm preaching to the choir, but just really try to optimize all other areas of your fertility. Sperm, making sure they're, not wearing, tight underwear and being free, all of these things. Try to optimize all of these other areas, because with the uterus, there's not a lot we can do about it, because we kind of know that it's there.
I'm going to put on my Andrea hat for just a moment.
Yeah, please do. I wish he was here. He should come to all of these.
I do too. The fact is, we're not able to get surgical hours when we want them. And I don't know what happened to the OR. So at like 3:00 in the morning on a Saturday, he's operating.
Oh yeah,
so
I know. He's a madman.
So Monday we left for the lives, but most Mondays now he's in the OR. So,
yeah.
But anyway,
yeah.
I'm going to put on my little
put it on.
because he's reproductive immunology.
Yes.
And so when you go to get pregnant, there needs to be this delicate dance between the host environment, which is usually the mother, and the embryo. And they have to recognize certain immune responses and reject certain immune responses. And one of the issues with certainly endometriosis causes a whole inflammatory response that causes a failure of that connection that needs to happen.
Right.
But adenomyosis, very specifically in the lining of the uterus, interrupts the immune response between host and embryo. And so the advice that you gave is exactly what needs to be done. You need to optimize everything else. So you need to optimize. If you have endometriosis, you need to remove the endometriosis in full, not burn it off a little bit, because burning it off a little bit does not remove the root of the inflammation. If you you can optimize sometimes through diet, you can optimize sometimes through lifestyle, but you have to do that optimization, because the adenomyosis is going to remain in the lining of the uterus, interrupting that immune response. And there you go, a reproductive immunology by a physical therapist.
No, you're right. You're right. And I think
he would say things like, also, these are the patients we love to use fish oils in. These are, anything that can change the inflammatory response can optimize the system. But leaving the endometriosis in those cases is not good.
No, because then you're fighting an uphill battle against two things. Well, endo's really not even just one thing, because it's affecting the egg quality and the tube and also everything. So yes, you're right.
Right. And you mentioned it very casually when you were talking about the underwear, but that also becomes the time when we really want to make sure that the sperm is optimized as well, because
it takes two to tango.
Right.
You got it. I mean, we're focused here on the women because it's a little more complex in our world, but theirs is just as important, because the quality of sperm that fertilizes the egg, it makes a difference.
But if you're going to talk about optimization, You won't be able to control what's going on in the lining of the uterus, but you will be able to do everything else in the body. I think that is the best advice, even without my little reproductive immunology hat on.
I know.
I
Yeah.
need one. I only have this hat. I only have, these are sold out, so we can't even use these. I only have this hat, but
Can't
it
wait to
doesn't
get one
say
of those.
reproductive immunology. But I think that that becomes a real thing. And we get these calls all the time. Like, I have adenomyosis. What do I do? The other thing is, I remove the endometriosis, right? And in
Yep.
removing the endometriosis, you may not increase your egg quantity, but you may get a little recovery in egg quality. We have a wonderful presentation by Dr. Siddiqa on our
Yeah.
YouTube.
Beba Honey. Yes.
Yeah, who's amazing. I
She
can't wait. It's
is.
her first
She's
year.
wicked smart. When I was in fellowship with her, I was always amazed at the statistics that she would show out. Because, she did an REI fellowship first and then a mixed
Right.
fellowship. Yeah, she's brilliant.
Well, her
Um,
and Zarik, it's Iraq.
mhm.
But he planned a session for the two of them for next year. So I can't, which is very RE and also Andrea's RE
Mhm.
and basically Meg. So like it's gonna be like
Yeah.
and Antonio, it's gonna be like a festival
Oh,
next
man.
time. I didn't get there
Okay.
yet,
Okay. You're like, I'm already planning ahead, just one year at
but
a time.
I never fully understand. She discusses it in full why that quality may rise by removing the endometriosis. So like
Yep. Yep.
even if people think they're going to use a surrogate, we still recommend the surgery because
Yes.
you have to get a better quality of egg out, right?
Right. And
Not
I
for
usually
everybody.
Yeah, I usually talk to patients about waiting, at least 2 cycles after surgery. Usually it takes that third cycle for the ovary to fully regenerate. So if my patients are coming in, planning to go through IVF, just depending on, kind of what their goals are, usually I say, let's wait to that third cycle after surgery because that's when you're like, eggs are going to fully turn over and get the benefit from endometriosis surgery. And we just flush the tubes. You're still kind of optimized for success there at that point. So usually that's in tandem with their fertility doctor, but usually that's kind of the route we go.
Yeah, so that's our shtick on adenomyosis and fertility. But I also want to say this because it came up over the weekend. When you have a fertility issue, you still need an expert excision. It's not, I could just go to someone who's going to take a little off because all I want is the baby, because it's
Yeah.
still affecting your overall health, whether you understand that or not. So
Yeah.
a disease that diminishes your egg quality, let me tell you, we started with menopause. We're gonna continue with menopause. If it's affecting your egg quality, things like Parkinson's, Alzheimer's, bone loss, heart attack,
Mhm.
stroke, those
Yep.
aren't good things. So
Yep.
you need to remove the disease so it stops affecting like your
Yep.
whole body, driving you into these ill elderly experiences.
I think that's something we forget to talk about because a lot of times we're in the moment, like this is your goal. Your goal is fertility. Your goal is pregnant. Let's meet this goal together. But there's
Yeah, but
so many longevity.
people go like, I'm just a little bloated and I want a baby, so I could go to anyone. And I'm like, no, first of all, you're bloated. That's called endometriosis, when it comes
Yeah.
together. But
Yeah.
you deserve the excision. Now we could talk about access to excision in a different
Yeah.
line, but
Yeah.
you deserve it. It's not just I'm trying for a baby, so I'll do a slap job to get the baby. You
Yeah.
deserve to have the overall health
Yeah.
benefit.
Well,
Yeah.
and there's no shown benefit to going in and getting a like cauterization of the endo in fertility. Zero, because it doesn't make sense. If you don't remove all the abnormal cells, you're not going to see a benefit. I mean,
Yeah. And you are going to see a benefit with excision, in my opinion. Okay, well, we're gonna get on a I'm gonna get on a platform and start a riot any minute. So
I'll be there with you. I'll stand
well,
next to you.
we'll
I'll hold
see.
a picket
Next week
sign.
I'm going to DC to actually start a, well, I shouldn't say that these days, but next week I am in DC
Be
with
careful.
American Urology Association. So we had
Oh,
a question so important that I had to translate it from Spanish to English.
okay.
And it is something we haven't touched on yet. Can adenomyosis invade the cervix? What is the relationship between adenomyosis and the cervix. And then I'll share
Yep.
with you a fun fact I never knew till this summer.
Yeah. It can, even though it doesn't do it as often. Adenomyosis can go into the cervical tissue, and I've seen it. Unfortunately, I get sent women frequently who've had super cervical hysterectomies because they're easier for whatever reason, and I have to go in to remove the cervix specifically, which is actually much more difficult surgery than just removing it at the beginning. And we get pathology positive adenomyosis all the time because there's still cells that are left in there, and it's frustrating. Does it typically, that's not the first place it starts, but it certainly can spread there.
Yeah, so there's a lot of discussion. We were originally supposed to have Corey on, but she had a technical issue this evening. But there's a lot of discussion about the cervix and also sexual sensation and
True.
orgasm.
True.
And so I see patients and also prolapse who's
Hmm.
get a better cuff with it. But I see plenty of patients who would love to keep that cervix, but the concept is typically if you have adenomyosis, it's going to have some and endometriosis, you're going to have some sort of disease in the cervix as well. What do you think?
And I actually had I rarely do cervical hysterectomies because usually I'm doing it for adenomyosis, but it's very much of a shared decision making. I actually did a cervical hysterectomy 2 weeks ago. Probably first one I've done in 6 months. She had endometriosis. I knew that she had adenomyosis in her cervical cells. I could see it. I tried to cut it out, but she really wanted to keep that cervix. So she knew that risk, and that's what she chose. And that's also okay. It's okay to make decisions for your body, knowing your risks, because her biggest concern is a cuff dehiscence. She said, I'm type A. I'm always going to focus on this, and I cannot live with that risk. And I like mentally am not okay with it. And that's okay. It is her body. I can make decisions for her. And maybe there's a chance down the road she's not symptomatic from the adenomyosis because I cleaned up, she certainly had endo. I cleaned up all the endo, and maybe those cells won't be as symptomatic down the road. But I do usually recommend the taking out the cervix with adenomyosis. But I also, when I close the cuff, I incorporate all the ligaments that were holding it up. Cuff dehiscence is very low. I do a nerve sparing hysterectomy, so I try to avoid all of the clitoral nerve roots. Most women get like sexual sensation not just from the outside of the clitoris, but the clitoral nerves that are running at the top of the vaginal walls. I do have some patients though that do have sexual stimulations from deep cervical penetration, and so we talk about these. These are all things that are really important.
Right. Most, I'll tell you, because I think they end up in pelvic PT. There
True.
is a
Sure,
loss.
you see them down the road.
There is a loss of the sensation of uterine orgasm, right?
Mhm.
So patients, it's very important if you're watching this, you should be asking these questions.
Yes.
That notion that when Dr. Haverland does the hysterectomy, she's making sure to avoid certain nerves. Those are things you need to start asking your doctors about, very important.
Yep. Yeah.
Yeah.
And they are. And again, even if I recommend that this, keep removing the cervix, doesn't mean that you have to do it. Very much of autonomy, at least in my practice. I feel very strongly about that.
Yeah, I'm just checking I'm checking all the questions. Oh, that's a good question. We didn't talk about that because I don't love them, but we'll see. What is your feelings of first of all, what is a PSN and what are your feelings on it?
Pre-sacral neurectomy. I'm assuming that's, yeah.
Yes.
Okay.
Not pumpkin spice latte.
Yeah. That sounds nice. So the pre-sacral neurectomies, I actually was trained on them in residency. There we had a physician in Phoenix and Scottsdale that was doing them. I don't see a lot of benefit from them. It's a very specialized procedure where you take out a small subset of nerves around the sacrum, the pre-sacral space. However, if you take too many nerves, then you have chronic constipation, maybe even worse than you had before. It can affect orgasm. It can affect your bowels and your bowel emptying. And at least in my experience, I don't see a ton of benefit. I've had women who've come to me and had like 3 or 4 presacral neurectomies, and I'm like, well, what's the point? Why are we still doing this? Because it's not helping, and every little bundle of nerves that we're taking out just gives you higher and higher risks. So I personally don't do them, but I have plenty of patients that I've seen that have had them in the past.
I think
I'm
that
open to your, everybody has a different opinion about this, but
everybody has a different opinion. This could be a good one to ask our full panel at the Endo
yeah,
Summit. I'm not a fan ever of severing a nerve, because nerves are a beautiful web that we're born in our body with, and I'm not a fan of that. But I have seen plenty of distended bloating that won't go away after a presacral neurectomy. I have seen urinary urgency. I have seen
yeah,
urinary frequency. I have
yep,
seen plenty of bowel dysfunction. I've seen plenty of patients go back to the doctor and the doctor denies that it could, after I said, do you think it could be the presacral neurectomy? The doctor denies that it could be the presacral neurectomy. I've seen a few who have had some trouble with labor after a presacral neurectomy, but kudos to them that they got pregnant, because
yep, sure.
that was the purpose of for them, those particular patients, but ended up having some labor issues. And then I think the nail in the coffin for me in the presacral neurectomy was I went to the St. Louis anatomy course last year. And
Mhm.
you came through a MIGS fellowship and saw all those nerves. But then once I saw how fine and
Yeah,
delicate everything was, I just wouldn't want to start, you should only take like one fiber, but the
yeah,
bundle has 10 fibers in it. And how do you know, I'm not a fan.
yeah,
However, I understand that there are people who want to use that almost as a uterine sparing technique. And as long as
yeah,
they're educated on the risks, that's their
yeah,
choice.
yeah. Risks, but I feel like the benefits are just really minimal, at least from the patients I've seen. So it, I think it can be a discussion with some providers, but I don't offer it usually.
I think one thing I like to point out to patients is while endometriosis will not improve with menopause because it's still an inflammatory disease,
Yes.
many people who go into menopause with adenomyosis see a huge improvement, especially when they start having to HRT with progesterone, right? Because progesterone is very like nourishing to the
Yep. Yeah.
to the adeno. So
Yeah,
I
that
think
that is a benefit, and I'm glad you brought that up, just because it's some hope. You're like, thank God, I got my endometriosis out, years ago, and I'm waiting to get this. But yeah, I agree. I've seen the same in my
right. It's not
practice as
like
well.
I would say to someone like, "Hey, wait it out 10 years
Yeah,
and see if you
no,
got," but
don't
it's
suffer for
something to
5 more
think
years.
about.
Just yeah,
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 food for thought almost, because I think people are crippled. People who with adenomyosis, they're crippled by it.
yeah.
And unfortunately, they're forced to make very unpleasant decisions.
Yeah,
Yeah.
especially when they're in the thick of it. I talk to patients when they come in and they're in like a huge flare and having, just debilitating pain. Like, it's really hard to make focused and reasonable decisions when you're in so much pain. But we talk about that, and sometimes there's no way around it. But it's also something important to talk about. Like, hey, here's where we are. This is what we're due for you. But let's touch base again next week too, just to make sure that we're still on the same track, that we haven't changed our mind once maybe you're in a little bit better place.
Yeah. Now, another question we got is, do you see cuff endometriosis or cuff adenomyosis?
I have not seen cuff adenomyosis, but I do see cuff endometriosis relatively frequently. And a lot of it's because women have come to me and been told that the hysterectomy is going to cure their endometriosis, and they haven't had an excision. So it was never removed in the first place, and it's still there. Um,
And then
but
how difficult is that to treat?
Well, it actually is a little bit harder. If we just remove it the first time when you have your first surgery, and I talk to patients about this, your first surgery is so important because we can get really wide margins. You don't have all this scar tissue around. There's a much better chance that it doesn't recur. But post hysterectomy vaginal cuff, it can be tough because the bladder can kind of scar down, the rectum could scar down. Usually we have to, separate them and then reclose the vaginal cuff. And I do it frequently, but it's certainly easier just to do it right the first time.
Yeah. All right. Well, as we round out our hour with Dr. Haverland, I wanted to just share mistreatment of adenomyosis led to the founding of the Endometriosis Summit. That's really how we ended up on this great big wild journey, because
Cool.
I was personally told, they looked at the measurement on MRI and said, well, it has to come out. And I was like, I have connective tissue disorder, so maybe we should discuss this first.
Yeah.
Nope, if I see, I'm gonna share. If I see 12 millimeters, that's it, it's gone. And I was like, well, I'm not willing. And I had to really dig my feet in, to which then there was like a fellow in the room who told me that all people over 40 with endometriosis need hysterectomies. This was in a very high-end specialist practice. This wasn't in like your average on the street doctors, right? So then I was told that. Then there was also a discussion where when they did the ultrasound, I said, I'm going to keep the uterus. And they said to me, why? Because you're going to have a surrogate. And then they laughed about it. Right. That was
Golly.
not working out good for me. And then the final straw was I wanted to keep my cervix for connective
Yep. Yep.
hypermobility issues,
Yep.
but
Sexual
also for
function. Yeah.
sensation. And the answer was just no. So these are all the things you should not. And so I don't know in that moment what happened, but I ended up leaving the office, and I had met Dr. Vidali, but I didn't know him really well. And I sort of was like, I'm gonna either like go sit in traffic in Central Park West, or like I don't know what to do. And so that's
Yeah.
actually how we became more than
Yeah.
Instagram friends, right? That
Yeah.
was because he was like, well, I don't think you should sit in traffic and let something, like, I don't think that that's a good idea.
Yeah.
And so ultimately, that's how the Endometriosis Summit ended up being founded, because if you're a patient and you know you don't want to lose your cervix, or you know
Yeah.
I was young enough to remove the adenomyoma, or you don't want a hysterectomy and nobody's
Yeah.
listening to you,
All of these are good reasons. Yeah.
then there's a failure to provide care. And that's what we wanted the world to know, that like
Yeah.
patients are really in control of their cases. That's how the
Yeah.
Endo Summit was really like
Yeah.
founded.
Sally,
Yeah.
I'm sorry you had that experience,
But
but
it
look at
has,
you now,
so
girl.
listen,
I
I'll
mean,
share that.
you were advocating for thousands of women. I mean, do you even know how many lives you've touched?
No, so but
By doing, I'm serious.
let me
It's
share that
amazing.
the end of the story is because I had had a botched surgery where they took an ovary without consent. I went into menopause very young. And
Mhm.
so I was able to do a complete excision, remove the adenomyoma, and keep the uterus. And I feel like I take progesterone, and I sort of got lucky that way, because I don't think everybody is going to be in that boat. And
Yeah.
honestly, if I had to go through another like 10 years, which at the time I went into menopause, most people would have had 10 more years. I don't know that I would have been able to make that decision. So,
Yeah.
but it worked out for me. And I think the reality is, if you're sitting in an office, like somebody's telling you, like, you're like, I want to have a baby, and the doctor's like, the junctional zone is 8 millimeters. Are you crazy? You could just be crazy, because you're the patient. You're in
Yeah.
charge.
Yeah.
Yeah.
I agree with that wholeheartedly. And I hope that I exude that in my practice. I certainly try to, because it's infuriating what these women have been told. And some of it is not evidence-based at all. It just is easier for the doctor.
I
I
mean, I
mean,
have a high-end advocate, right? And she had a hysterectomy with ovarian removal. I don't remember the
mhm.
reason why she chose to remove the ovaries too. And then she was like really sick. And I'm like, because you're going into menopause, like it's called surgical
Yeah.
menopause. And she called the doctor for a recommendation for somebody to treat the menopause. And this was the recommendation. This is also a high-end excision specialist who, thank God, has retired. He says to her, you're no less a woman without ovaries. That was the recommendation. And this is what these are people, like I'm telling you, I already had a whole career in endometriosis when that happened to me.
Yeah.
Anybody on the street would have like died to work with Sally Sorrell, right?
Yeah.
The person that was told to, huge
Yeah.
endometriosis advocate, you are no less a woman. I mean,
Yeah.
like, that's
I would
not
have had steam
justification.
coming out of my ears. Like, yeah,
I've
it's
seen
and
MDs told shit like that, though. Sorry, I
yeah,
should curse on
yeah.
YouTube.
But when you're not like I mentioned this before, when you're not the one having to go through it, it's easy to say that. But there's so many benefits. And also we know this that removing your ovaries does not decrease your risk of endometriosis recurrence. And I also get people told that all the time. And then they're
So
stuck
frustrating.
and they have no choice. They're out. So you can't put them back in. And then we just have to deal with the next steps.
The next
Anyways,
steps are brutal. Like
they are.
really,
Yeah.
the next steps are tough. And so we don't want women to have treatments. We don't want people to have treatments that are ineffective. We don't also mentally, do you know what it's like to recover from something? I mean, you see it every day with your patients, right? We
I
don't
do.
want
I
to
do. But
recover.
yeah, it's hard. It affects you emotionally, it affects you physically. And there's post-surgical blues that it's very real. It affects at least 30% of women. And even if you make an informed decision, you can still have post-surgical blues because it's still a part of you missing. And there's nothing, it's not, it's normal, but it doesn't make it easy. It's just important to be aware of these things and talk through them and have a provider that understands.
Yes, all good things. Okay, as we wrap up, because we're over our hour, I'm sorry to your
Okay.
family. As we wrap up, the Endometriosis Summit is coming up March 28th through the 30th in Celebration/Orlando, Florida, and virtually worldwide. If you want a ticket, we are very close to selling out parts of the Endometriosis Summit. So do not hesitate to go to www.theendometriosissummit.com. What are you looking forward to the most about the Endometriosis Summit?
Well, if you come to Endometriosis Summit, don't be late because I'm Friday morning. It's 7:50 a.m.
Oh yeah, that's right.
Um, but I'm excited about just listening to the collaboration of the surgeons and the neuropathology. I always love going through that. I get real geeked out and nerdy.
Yes, that we have a full 2 hours on neuropelviology. You should go abroad and take it. You should definitely. I also not only did the St. Louis course, which was amazing. I also got to do ISSA. I don't know how people were started to be like, why are you don't even operate, but I got to do all these high-end courses last year. And that course was
Yeah,
amazing. And
yeah,
the way it's designed, so it's designed without even, maybe it's because they're really good friends, but I don't think they ever even talked about it, Dr. Ceccaroni and Dr. Vidali.
yeah.
It's designed that it's not I am instructor, I give you, it's not authoritarian at
Right.
all. It's a very equal learning experience. I highly recommend that one. You would love that.
Cool.
I don't know if
Yeah.
a MIGS really needs it because a MIGS gets it.
I mean, I just love anatomy. I mean, I remember just spending hours in the anatomy lab in med school, like with the cadavers at that point were not very high end. Their whole room was kind of
Well,
smelly.
are
I
you going to
just
do
loved it.
our cadaver course?
I'm not. Maybe I should.
You should. You
Just for
should
fun.
do
Yeah.
our cadaver course because there's room in it.
I'll look into
Yes,
it.
and it's 3.75 CME.
Oh, well, that's
Fancy
always
3.75 CME because I
yeah,
gave
every
a
little bit helps.
15-minute break.
Yeah.
Yes, but I mean the Verona also has excellent pizza, almost as good as Naples. So I highly recommend the Verona course as well. Our course has a robotics element to it, which is very unusual, I hear,
Yeah.
for these
Yeah.
courses.
Well, it's fun to have a different perspective because, like a laparotomy excision and, anatomy lab is very different than from the Trendelenburg visual.
Now, I am looking forward to Ginger Garner will discuss the relationship between the throat, the diaphragm, and the pelvic floor. And for the first time ever, we have been approved, because I finally learned how to do it, we have been approved for 2 CEUs for physical therapists.
Oh,
So let's pack them in there, physical therapists. If
I
you're
love
out
it.
there listening, you should pack them in. I got to figure out how to get you all in there, but we are approved for CEUs in the state of Florida. And I heard certain states New Jersey does not, but certain states automatically accept if you're approved in Florida, they take your thing. But
Yeah,
I
I
didn't
think that's
know
great.
that. In MD, you don't have to go state to state. In New
Yeah.
Jersey, New York, Florida, you have to have CEUs in each state, and they don't all count. So all
Yeah,
of
that's
April and
brutal.
May, I
That doesn't
spent
make sense, but you know.
a lot of CEU. Anyway, all right, please register for the Endometriosis Summit.
It's gonna be so fun.
If you need scholarships, also feel free to reach out. We'll see you www.theendometriosissummit.com. Next week, we are dark because I am up on the hill with the American Urological Association. And then we return for the King of Thoracic. We will be here with Dr. Cernovo. I believe it's March 10th. So I will see everybody when we return. Thank you before we leave, give them your how do they reach you and all your socials, everything, how they get
So
you.
endoexcellencecenter.com, or my Instagram is at Texas Endosurgeon. But you can find all of our phone numbers, and you can email us, reach out to me on Instagram.
If you stand on my balcony and yell, Rachel,
Yeah,
maybe you'll answer. Yeah. Yes.
You'll be able to see me.
Yeah. All right. We'll see you at the summit, and thank you
Yeah.
for joining
Thank
us.
you for
Take
having
care.
me, Sally. Y'all
Oh,
have a
we
good rest
loved
of your
it.
night.
I can't wait to we got to do that, a panel, the whole thing. It'll be so good.
I love it. I'm
All
in.
right.
All
Good
right.
night.
Bye. Y'all have a good
Bye-bye.
night.